मतलब
Hello, can you hear me? Hello? Hello?
I can hear you. My name is Shukra.
Hi, and can you see me as well, Chuka?
I do. I can see you. Yeah.
That's great. That's great.
Okay.
Okay, we're not going to wait any further. Hello, welcome everyone who has joined so far, and all those who will join our Taste Survivor session. My name is Mina Gerges. I am the Associate Program Director for PrepMedico. I am also a breast surgeon, and I am in charge of the breast faculty. I'm one of the breast faculty in the breast mentoring for the course. Our session is expected today to run over around 2 hours. Okay. Can you see my screen?
We can. Yes.
That's great. So our session today will be one of three parts. The first one will talk about the Section 2 exam. I'm assuming that most of you, if not all of you, have passed Section 1 already. Congratulations. That's really hard. I always say that actually Part 1 is harder than Part 2. So we'll speak about the format of Section 2 exam. What is it? How is it calculated, and what to expect through it? The other thing is we've gone through the Viva essentials, how to answer the Viva and the clinical scenarios, just as a general approach. We will have few scenarios, not just to demonstrate what we have talked about with the techniques. Probably 3 or 4 scenarios maximum. I will ask whoever would be interested to volunteer to answer. I would be very happy with that. And then the third section of our session today will be talking about our course and how to make the best use of it, or what has it got to offer. Okay, feel free to stop me anytime to ask me about any questions. So the FRCS Section 2 Viva, that's a GCIE one. Of course, you know that there is another one, GCSFE, which is the international one, which has got a different format. That's particularly important if you are going through the Facebook groups and social media and inquiring about the details, because make sure that whoever is giving you information is talking about the right one. So it has got 2 parts. The first one is the clinical examination, and the other one is the Viva. Okay, with the clinical examination, it will be 2 parts. The first part is the general surgery clinical, and the other one is the special interest. That's the first thing that you should be aware of when it comes to studying for this exam. Okay, I would say that most of the time, at least 40% of your study is directed towards your specialty, and the other 60% is amongst everything else. That's why while you're preparing, it doesn't make any sense that you give, for example, if you're a breast trainee, it doesn't make any sense to give endocrine the same time that you give to the breast, for example, because half your study time should be breast. And that's become particularly relevant when it comes towards nearer to the exam, when time is very precious and when you just want to revise what is important for you. That's one thing. The other thing is the clinical examination, the clinical scenarios. They bear more marks compared to the Viva. Okay, and the long one bears more marks compared to the short clinical cases. So in the clinical, it will be one long case, which is 20 minutes. That's treated as a long clinical case where you have to go through history taking, clinical examination, and then you're going to discuss the differential diagnosis and the management. You can have either a real patient, you can have an actor, okay? You can have a previous patient who had treatment. You can have just a photo on an iPad presented to you, or sometimes the examiner tell you, look, I'm your patient, tell me what are your questions, and I will answer it. Okay, that would take 20 minutes. And then when the other 20 minutes, they come usually two short cases. Okay, it's very directed. They tell you, look at this photo, tell me what you can see here, or examine that patient's abdomen and comment on what you can see, or tell me what you think of this lump, for example, and so on. Okay, the same goes for the special interest. As I told you before, clinical bears more marks compared to Viva. That's why I would say the most important is the long clinical case in that whole exam. If you do very, very well in this one, it can help you to compensate for other areas that they're not your strength. And we all cannot cover 100% of everything. So if you go to the Viva next day, for example, and well, you missed anything, you get a case about endocrinology, incidentaloma, and things that you did not really study very well, and you did not pass that station, then these extra marks from the long clinical case, they can help you at that time. Okay, if you do not do that great in the long clinical case, it will take you really, really hard work to make sure that you are all very well balanced in the end. So that's something to be aware of. Okay, the other thing I would say, the FRCS, the team, the examiners, they are free to change the format if they need to. So for example, they might decide, I would like to do 2 short clinical cases and 2 short clinical cases. Or for example, no, I would like 1 long clinical case and 3 or 4 short clinical cases. No one can tell them no, that's fine. But that's not the norm. The norm that they would stick to that format, but they can change it, especially when it comes near to the end of the exam, or if they feel that, like, with the candidate, that the candidate is previously informed about what that long clinical case could be. And as you would imagine, that's not uncommon. Okay. So the other part of the exam is the Viva, and we'll talk in details about the Viva. Again, the oral and Viva are the oral Viva examination are 30 minutes each. There are 6 scenarios, 5 minutes each. So usually they tell you, you've got a patient who came with that. What do you think is that? Or how do you manage that? Or what do you think of that? Okay. The bell rings at 15 minutes. Okay. So they can do three scenarios in 15 minutes. They can do 4, they can do 2, depends on how well you do. The first one would be the emergency surgery, trauma, and critical care. The second station would be general surgery principles and clinical practice. The third one would be special interest surgery, clinical practice. And the fourth one is divided between basic principles, and that's basic principles of your special interest surgery, okay, which would be over 15 minutes. And the other half is the academic foundation. Previously, like about 2 years ago, the academic paper used to be relevant to your special interest. So if you're a colorectal, you get a colorectal paper to critique. If you are an upper GI, you get an upper GI. Right now, they changed that to be just general surgery, generic paper, rather than special interest. So again, if you see the format here, as I told you, that your special interest carries about 50% or 40% of the weight of the exam. That's why you're not allowed not to know anything about your specialty. Okay. The Vivas, they usually ask you 2 or 3 questions for every scenario, which is in about 5 minutes. They usually have got an iPad on the table, presenting to you either an X-ray or radiology to read, like CT, MRI, X-ray. Okay, and that's why one of the parts that is very important, you have to make sure that you are aware of it, is the radiology part of the general surgery. How to read a CT, how to read an MRI, You don't have to be an expert, but at least to spot the obvious things. An X-ray, obviously. They can present to you clinical photograph. They can sometimes in critical care they present to you something like an ABG or CPEX. It happened before. They can present to you something like an endoanal ultrasound if you're a colorectal, or upper GI manometry if you're an upper GI, things that are relevant to you. Okay, general surgery principles, that's something that, so let's go back. Emergency surgery, trauma, critical care. Half of that is related to the ATLS curriculum. Okay, and they can ask anything about it. ATLS curriculum, something they can ask you about pregnancy, child trauma, burn, trauma to anything, vascular trauma, that's all comes to emergency surgery. Anything that perforates or bleeds is emergency surgery, okay? Anything that perforates or bleeds is emergency surgery and trauma. Okay, with the general surgery principles, that's usually it's very elastic. You cannot control what they should ask and what they shouldn't. They can ask anything from hernias to splenomegaly to purpura to amyloidosis, anything like that. All this, and that happened before. Okay, and as I told you, with a special interest, they can ask whatever they want. Basic principles. Usually that's the most tricky in the FRCS Viva, because if I ask you basic principles about the anatomy of the physiology, about your specialty, it's not a clinical scenario. It's either you know it or you do not know it. You can improvise. There is no clinical sense here. Okay, so either you pass it with flying colors, you get a full mark, or you fail it. That's why I would consider this one probably the most difficult amongst all this. Okay, anyone has got any question, feel free to stop me while I'm doing it, so it's fine. So what's expected, or how is that different from part one and from the MRCS? You are expected to be a first day consultant. Okay, so you are expected, and that's why you find most of the scenarios would be you pass the exam, you're appointed as a consultant, that's your first day, and that's why you can do. So you're not like an expert in the very, very difficult cases. That's why there is no shame saying I will call for help, I will ask a senior colleague, anything like that, but you should be able to make safe decisions. 50% knowledge and the rest is 50%. And that's very important. Knowledge gaps are not the most important thing in the exam. They're 50%, but the other thing is how you can take sound decisions. How can you take difficult decisions? At which point you would not operate? Okay, when would you call someone else for help? When do you know it's your specialty, not specialty of that? You have to have an attitude as you are discussing that with a consultant colleague. You treat you with respect. It's two-way. So it's not like an MRCS. The examiner is not treating you like he's a teacher. He's like a consultant colleague. The attitude of answering that is very important. I always advise and say, think of it like this. You're the consultant, and your registrar is sitting with you in theater reception, theater coffee room, asking you about this, and you're explaining it to your registrar. That's how you should approach the exam. Okay, confident, respectful. Okay, you're not inferior, and you're not patronizing the examiner as well. Okay, they assess how you think. They assess your process and reaction to the scenario rather than telling the correct answer. There will always be a question that you don't know the answer for. There will always be a difficult situation. They would like to assess how will you react to unexpected scenario, for example. Your approach is more important than your answer, I would say, because for some question there is no single right answer. Okay, how you approach it is the most important. Is what you do. Okay, we talked about that. You have real patients. That didn't used to be the case during COVID. They would not allow patients or actors. That would be just photos on iPad. But now you will have real patients. You can have actor. You can have past patients. Okay. The questions are built up from easy to more difficulty. So they start with an easy, and we'll talk about that in details later on about when we talk about the anatomy of the Viva question and how is it structured and how should you answer it and what to expect. We'll talk about that later. Common things are common. You do not get extra mark for knowing the extra rare disease that can cause that symptom. That's not how we do it in real life. So you start by the common things. And they used always to say that's the difference between the surgeon's way of thinking and probably the physician's way of thinking. They start thinking about what's the rare thing to do first, but we think about common things that common. Evidence, yes, it is important. It's not the most important things. You have to understand that trials are not the most important thing in the world. No one failed because they did not know the trial. Okay, and again, that will show better when we speak about the anatomy of the vulvar question. As I said, you are day one consultant. It's fine to say, I do not know, but you need to have a plan. What will you do to know? Right? You're going to ask a colleague, will you ask someone else? Do not try to improvise some questions because then, sorry, some answers, because then you will dig yourself into a rabbit hole. Once you start saying something very odd, okay, most examiners will, some examiners will say, no, that's wrong, and then they will just cross the mark. Others will not do that. Others will say, oh, you said that now, tell me about it. How will, so for example, if I will relate more to the breast. Have we got any breast trainees here? Just raise your hand if you are. No. Okay. Right. If I tell you for a scenario, for example, it's I've got a patient who's pregnant and she's in late first trimester and she's got breast cancer. What would you do? We'll speak about that in details, or you will know about that when you start studying that you cannot give chemotherapy in the first trimester. So, and you cannot give radiotherapy in pregnancy. So the answer you ideally should be neoadjuvant chemotherapy. You should wait till the beginning of the second trimester and give neoadjuvant chemotherapy. If your answer would be a mastectomy, which is a wrong answer, okay, the examiner will not tell you, oh, that's wrong. He will tell you, oh, mastectomy, that's fine. You have done a mastectomy and the patient needs radiotherapy. How will you give the radiotherapy now? And then you start improvising some answers rather than saying, I did not know. Like, we will counsel here for abortion. We give radiotherapy with shielding. All these are wrong answers. But what you have done to yourself, rather than saying, I do not know, you started bluffing, okay, making up some answers, which will put you in further problems, and then you will find yourself saying things that don't make any sense. Okay, remember, the FRCS exam is a very stressful exam. It's very stressful. It's very expensive. You paid a lot of time. You've got a lot of money for that. You are sitting for the exam somewhere 100 miles away from your home, from your children. You're sitting in a hotel, so it's a very stressful time. Level of knowledge required, and if you go to the general surgery curriculum, you can find that. If for elective general surgery, all candidates are required to know up to the ST8 curriculum. Okay, that's for the general and emergency as well. Okay, when it comes to the upper GI, I'm speaking about general candidates. If you're not an upper GI candidate, you are required to know ST6 level. If you are upper GI candidate, you need to know ST8. Similarly, for colorectal, you need to know up to ST6 level knowledge. Okay, if you are a colorectal candidate, you need to know ST8. Transplant, if you're not transplant trainee or a breast or endocrine or vascular, you need to know up to ST4 knowledge for that. If you're not sure which topic falls under that, you can always go back to the general surgery curriculum to find, oh, is that my level, or should I know that, or I shouldn't? Okay, so how is the exam marked? Okay, for every question, it's marked out of 8. When 8 is the full pass mark. Okay, you can get either anything from 4, 5, 6, 7, or 8. Okay, anything 6 or above is a pass. Okay, 5 and 4 are fail. Okay, they assess here to different domains. One is the overall professional capability in patient care. One of the other domains is knowledge and judgment, quality of response. Are you someone who is organized, who have got a scheme or not, and bedside manner, that's more relevant to the clinical. Okay. This is on the GCIE website, by the way. You can access that, and you can how they assess you. Okay. Right. This is a very important slide. What are the causes of failure? Why do people fail the FRCS exam? There are three reasons for that. The first one is knowledge gaps. As simple as you do not know enough. Your knowledge is not high enough for the FRCS level, for day one consultant, or for the ST8 level in your specialty, or the others. Okay, so simply you do not know the answer. Second thing is poor Viva technique. Your approach to the question has not been right. You lack of situation awareness. You did not you've got an unwell patient in the ward, and you did not consider even moving the patient to the HDU or RTA. Your body language during the answering the exam, that's very important. And yes, they assess you against that. Eye contact, inappropriate use of jargon, especially if you're doing something like consenting a patient and saying some medical jargon you shouldn't be doing. That's the second cause of failure. The third one is poor stress management. It's very stressful, and you become very stressful during the exam, and you perform very badly in one station. Okay, and then when you go to the following station, you cannot focus or cannot answer it. Out of these three, which one you think is the commonest cause of failure? Anyone who can think? The commonest one is the poor stress management, really. The commonest cause of failure is not knowledge gaps. Remember, your knowledge has been assessed in part one, mostly of it. Okay, so knowledge gaps is not the common. It is a cause of failure, obviously, but it's not the common. The commonest one is poor stress management. As I told you, especially that this is a very stressful situation. Okay, it's a very important milestone in your career. It has got a very unique environment. The second most common cause of failure is the poor Viva techniques. So if you have sit for the exam before and you failed, if you're a resitter, you need to be aware, why did you fail? What was your problem? Was it mainly because knowledge gap, or stress management, or your Viva technique? Because the last thing you'd like to do is to address the wrong reason, the wrong cause of failure. And we all see that. Someone has sit for the exam, they did not pass, which is a very common statistically. If you are not a trainee, your chances of failing on the first attempt are more than your chances from passing. Okay, and that's statistically from the GCIE. So you sat for the exam, unfortunately did not pass. So what you decide to do is to get every single companion book and read it, all of it, to make sure that you're not missing anything. All right. The question is, are you sure that you failed because of the knowledge gap? You need to identify your weakness and work on it. It's not always the knowledge gap. Sometimes it's a Viva technique. Sometimes it's stress management. I recall one of our previous candidates who was sitting for his fourth attempt, actually, and I was doing one-to-one session to him, and I spotted that he has got a very big problem. He never makes eye contact with the examiner. Always when he thinks about the answer, he's rolling his eyes up and looking up in the ceiling. Okay, and also his Viva technique, he always jumped for the state-of-art answer trial that no one does actually in real life or in our NHS hospitals. So, and what he was doing during his previous attempts is he was trying to polish his knowledge. Actually, his knowledge was flawless. It was not how much information you have, it is how do you present that information. So, how to prepare? First of all, know who you are. You need to understand your strengths. You need to understand your weaknesses. You need to know how would you address that. Okay? You need to assess what you need. So If you are strong in your subspecialty, that's great. If you have never worked in a transplant, in a hospital with a transplant department, you've never seen transplant patient, believe me, that's what you need to focus on, just to familiarize yourself with ST4 level knowledge. Have you done any vascular before? Can you remember it? Because that's part of your curriculum. Have you done any endocrine surgery? Things that we don't do. Well, if wherever you worked in the UK, you had some exposure to colorectal and upper GI. Okay, and that's why these are the two things that you're required to have ST6 knowledge, not just ST4. But I need to identify your weaknesses. Okay, there is no certain way of preparation that would suit everyone. Okay, you need to understand whatever suits you, whatever easy way suits you. Join one of the courses. If it's not this course, join other course. Do not just fly solo. You cannot assess yourself. Okay, you need someone to assess you and to guide you. It's very important. Invest and sacrifice fully. You need to do your due diligence. There are no shortcuts. I've seen that before. There are some people who say, "Oh, I know that very well. I've just passed part 1 exam. What I will do, I'll just get previous year records and just go for this." There are no shortcuts. It's an exam that you need to study very hard to pass. It's very easy to pass. It's very easy to fail. So, did anyone has any questions so far? You can still hear me, can't you? Just raise your hand if you can still.
Yeah, we can hear you.
That's great. That's great. If you got any questions so far, feel free to stop me. So, another before other question, I think that's a very important thing before even started in studying, is you need to understand how me as an examiner formulate the question, so you can understand as a candidate how you answer that question. Okay, that would tell you a lot. That would tell you a lot. That Viva question, it goes through 3 phases or 3 stages. The first one is an introductory question. And the second was complication and decision making, and then goes to high critical thinking and knowledge testing, the higher knowledge testing. Let's go with the first one. The first one is the introductory question. In the Viva, let's assume I am asking you about cholangitis, okay? CBD stone, a very common scenario. I will not ask you what are the symptoms of cholangitis. I'm going to tell you how to assess it. I will not even tell you the word cholangitis. I will give you a presentation rather than a presentation. I will tell you, look, you are the consultant on call. You've got a patient in ED. That patient is presenting with jaundice and has been unwell. The patient has fever and the patient has pain. Okay, what would you do? Okay, few things. First of all, you need to follow a scheme, and that's what shows that you have got you are very organized thinking. You need to follow anything like ATLS if that's a trauma patient, CRISP if that patient has become well. That's a septic patient. You need to do sepsis 6, and you need to say that in the exam. You need to say, that's a septic patient. I will follow the sepsis 6 protocol or the ATLS. Even history in examination. If that's a breast case, you need to do a triple assessment. Okay, any classification. So I need to understand as an examiner how you approach the case. Okay, it's a very common pitfall just to say, oh, that's a case of cholangitis, spot diagnosis. There is no thing as a spot diagnosis. Okay, I need to know if you get a very odd presentation or a very odd disease, you've got a scheme to that. And these pitfalls, unfortunately, they are very common amongst the experienced candidates, not the fresh one. If you are someone who moved to the UK, you have been working as a consultant in your country, you are the most experienced, but that's mostly that we see. We've been doing that course for a while. So there is a syndrome called SSS, senior surgeon syndrome. Okay, that's simply a senior surgeon who we can tell from the spot, oh, we've got someone who has got pain and jaundice. Oh, that's cholangitis. It's great, you're right, but you will fail at the exam because you did not follow any scheme. You did not show me how you approach it. You did not show me even if it's not cholangitis, what else could that be? Have you got a differential diagnosis or not? The other thing is situational awareness. Okay, you've got someone who's septic. You've got someone who's unwell. Have you considered calling an ITU, HDU? You have someone with breast abscess, or someone who had a breast implant last week and is unwell. Have you considered calling a breast surgeon? Okay, you've got someone who's got Burhoff syndrome. Have you called an upper GI surgeon? You are being called over the phone to assist a patient in ED. You have to say, I will go down and assist that patient myself. Okay, so situational awareness is tested here. Okay, before we go that, this very first part of the question, it says, what will you be asked about? You don't get any marks for answering that right. How do you expect as an FRCS candidate to get marks just for knowing the ATLS, the ABCDE? I should not give you mark if you do not know that, but I wouldn't give you mark for knowing that. Okay, but you wouldn't progress to the second phase of the Viva unless you know that. Okay, and that's why I do not expect 3 marks just for knowing triple assessment or CRISP or ATLS, but you have to say that. Okay, I will not. You have to say the diagnosis. I will not say that to you as an examiner. I will not tell you how do you diagnose cholangitis, but I will tell you you've got someone with jaundice and pain and fever, and then what could that be? Okay. The second phase of the Viva question is the complication decision making. That's the bread and butter. That's when you get the marks. That's where you pass or fail. Okay. Based on the previous answer, you said, oh, that's a patient. I'll do the CRISP protocol. The patient is unwell. I will go assist the patient myself. I will need to know the news of that patient. I'll need to know fever, anything like that. If the patient is septic, I'll do sepsis 6, and I will examine the patient. The patient's got right upper quadrant pain. He's jaundiced. He's got fever. I would say that I need to rule out things like AAA, okay, or perforated peptic ulcer, but that's most commonly is cholangitis. Then you said the word cholangitis. Then I'm, as an examiner, tell you what is cholangitis, how will you manage it, what's the next step of the management, okay. I need to know exactly how will you approach that as a consultant, okay. Do not keep seeing testing situation when it's again. So, and that happens when you get a case outside of your specialty, and you certainly will. You're a colorectal candidate, but you get a patient who has got lactational abscess. You said in the first phase, I would call a breast surgeon, okay? Do not go repeating that. That's one of the very common pitfalls as well. Situation awareness is not tested here, okay? I do not keep telling me I'm a colorectal candidate. I'm a colorectal surgeon. I don't know about breast. The examiner knows that you are a colorectal surgeon, right? Of course, I will not get a breast candidate, give him a general case scenario about breast abscess. That would be below their standard, below what I'm asking them. I know that you're not a breast surgeon. Do not keep telling me that. I want to know what a breast surgeon would do. Okay, and also the other extreme is skipping that bit because you have practiced a lot. You know that when you tell the examiner, I need a breast surgeon, the examiner will tell you there is no breast surgeon, but please do not skip it unless you're told. Okay, there is a story about a breast candidate in the FRCS exam who had a trauma scenario, and it all went about, oh, the patient had head trauma. She said, I would call neurosurgeon. Well, you work in DGH, so there's no neurosurgeon around. Fine, I'll do that. And then it goes, there's an abdominal trauma, the patient's unwell. What would you do? She said, I'll take him theater. There's an examiner told her, is there anything you would consider before going to theater? Then she said, probably yes, I will check if there's an intervention radiologist, but I'm assuming there is no one around. He said, well, this time there is one around. So again, don't assume that's the norm. Okay, you have to say that yourself. Okay. At this stage, you need to support your answers with evidence as possible. You need to say that you will treat this according to the NICE guidelines, or that's the BSG guidelines if that's an upper GI case, BHS, which is the British Hernia Society, ABS, Association of Breast Surgery. There are some guidelines for everyone. If you're asking to consent a patient for any reason, please make sure that you are aware that when consenting a patient, you cannot just say there is a risk of general anesthesia and bleeding and infection. You are a consultant. I do not want to know that there is a risk of bleeding infection. Of course, there is a risk of bleeding infection. I need to know the figures of that. What is the risk of? You have to quote that in figures and percentages. If you got an actor, please avoid medical jargon. Okay, you will lose marks for that in the exam. Okay, always discuss alternative treatments and consequences of not accepting the treatment if you've been asked about that. Okay, then after the skin phase, you go to the high critical thinking and knowledge testing. That's when they ask about what are the trials, what are future prospects, what everything is very complex. If you've reached this stage, congratulations, you passed. Okay, you will not fail if you don't do that. And that's the part where you get asked about what are the trials, what are the future prospects, if something happened unexpected, are there any controversies in the management? And that's here the pitfall. If you fail to answer this question, you will not get the 8 in the scenario or in that station, but you will not fail. Okay, so, and you will not reach that stage. You will not reach that stage unless you go to the first 2 stages. That's why it doesn't make any sense just to focus on the trials and the evidence and all that and make the bread and butter of the Viva itself. Okay, no one failed the exam because they did not know the trial. Okay, but if you know the trial without knowing what I told you before, you will never reach to that stage when you would be asked about the trial, and they will not ask you about the trial if you don't know what's the management. Any questions so far? Okay. Let's discuss a few scenarios and see if we can apply what we have discussed now. I will need a few volunteers, please. Have I got any? Joker?
Okay.
Yeah, I'm noticing. So don't panic.
Yeah, sure, no worries.
Right? Okay. Let me ask you the first scenario. Joker, you passed the exam. That's your first on-call consultantship over the weekend. You've been asked to review a patient on the ward. Okay. The patient had emergency laparotomy and Hartmann procedure yesterday for perforated diverticulitis. Operation was done by your colleague. The SHO was concerned at the skin around the colostomy is swollen and red. How do you manage it?
Sorry, I didn't catch the last sentence. What did you? What was
Okay. It's your first on-call consultant shift over the weekend.
Yeah.
The SHO is asking you to review a patient. The patient had emergency laparotomy and Hartmann's procedure yesterday for perforated diverticulitis.
All right.
The SHO is concerned that the skin around the colostomy is swollen and red. How will you manage it?
First of all, I'll approach the patients according to CRISP protocol, and I will take a focus history and examination. This goes along together. I will then examine the patient myself. You mentioned that he had Hartmann procedure yesterday. I would like to look at the operative note. I will look at the documentations, and I would like to look at the drug chart as well. And then I will examine the patients.
Okay, so I will tell you what are the findings so far.
Okay.
The patient is 65-year-old, diabetic, type 1 diabetic. The patient had perforated diverticulitis yesterday. It was fecal peritonitis. The patient has a drain and he has a laparotomy. He is awake but drowsy. On general, he has got temperature of 39 and he's using 9. On clinical examination, the abdomen is soft and lax. It's not distended. The stoma itself is healthy, but the skin around it is very red and swollen.
So I would assess this patient as mentioned, and I'll I will assess him according to sepsis 6 protocol, and I make sure that he's having oxygen. He is having.
What is 66 protocol?
It's to take 3 and give it 3 from the patients, basically to take blood, to check urine, and to check the lactate, and to give oxygen, to give fluid, and to give antibiotics.
Okay.
So when I assess the patients after the examination, you mentioned the findings. I would like to make sure that he's having large pore cannulas, he's receiving fluid, he's receiving antibiotics. As I mentioned, I need to check his drug chart, and also I would check his bloods, make sure that he's like we check his FBCs using his CRP, and
So
we check the lactate as well.
CRP is 190.
Yeah.
White cell count is 23,000.
What's his lactate? I checked his lactate as well.
CRP is 190, the CRP.
Yeah.
White cell is 23,000.
So he's septic. We did like to make just to see if there is a source of sepsis. You mentioned the abdomen is distended.
No, the abdomen is not distended.
Oh, sorry, not distended.
It's all swollen and red, very red around the colostomy.
Just the colostomy site. Okay. The colostomy, the colostomy itself, you said it's healthy. So I would just make sure that after resuscitations, and I make sure that he's receiving antibiotics, receiving oxygen. We check all the other things that I mentioned, the urine, and make sure he's well hydrated. I think I would arrange for him to have a CT scan just to see if there is any collections.
What's your working diagnosis?
Well, there is. It's either wound infection, very unlikely to happen first day post-operative. I just wonder if there is a collection and if there is actual. I need to look at this. Well, the stomach looks viable from outside. I'd wonder whether it is from inside is not viable.
What do you mean?
You mentioned it is healthy, but I just wonder whether it is ischemic or any sort.
How can you feel
that? To examine it from outside, I can just like shine a light just to see if it is healthy or not, and ideally, and to arrange a CT scan to see if there is any ischemia.
Okay. So to see if there is any ischemia.
Yeah, ischemia or fluid collections or any pocket collection around the stomata.
Is there anything you'd like to check before the CT? Things like the drain, for example. I told you he has a drain.
Yeah, you mentioned a drain, but sorry, I didn't ask about it. Ideally, yes, I would like to.
There's nothing outside the drain. He had a CT. The CT is showing only normal post-operative changes. There is a skin edema around this colostomy, okay, with gas, and there is free gas inside as well. But remember, that's day 1 post-laparotomy. Do you expect to see some free gas or not?
Sorry, free gas where?
So the abdomen has got free gas.
Free gas.
Okay.
Yes.
Would you expect that to be normal or not?
Free gas, like it depends how much it is. Yes, it is.
He had laparotomy today, didn't he?
Yeah, normal. Yeah.
Okay, and you'd expect some free fluid as well.
Yes, not too much of it, but yes.
Okay, right. So so that's what we got at the moment. If it's not ischemia collection, what else could that be?
It's so many things actually, but I would like to maybe speak to the surgeons who operated on this patient just to see if there is any thoughts to start with. This is one. Second thing is, as a differential, ischemia, perforations, necrosis, the skin itself. It's very early to cause like wound infection, very early.
Yes.
But I would just see if there is. You said fecal contamination, just in case if there is any necrotizing fasciitis, just in case.
What is necrotizing fasciitis?
It is infection of certain bugs, microorganism, which is involving the mucocutaneous, the cutaneous field, or within the abdominal wall, like not involving the muscles,
Okay.
and that will be involving the skin as well.
Okay. Okay. And what are the predisposing factors to necrotizing fasciitis?
I think there are four classifications. One of them is polymicrobial. The other one could be streptococcal, and the other one is fungal, and the other one is
Okay.
mixed.
You mentioned the causative organism, but that's not a question. My question is, what are the predisposing factors? Are there any people that are more likely to
a predisposing factor? Sorry, predisposing factor. He is a diabetic patient that you mentioned, and the.
So I told you that the patient is septic. I told you that the patient is contamination and diabetic.
Yeah. I just remembered. Yeah, he's diabetic. Yeah.
So could it be necrotizing fasciitis?
It could be very
Yes,
good.
it could be.
Yeah.
It certainly could be.
Yes.
Right. So, how will you manage it?
This it has to be managed ASAP. If I made a diagnosis with that, there is Lernic classification assessment. You can take some blood, and depending on that, but it's not too reliable. It is mostly clinical indications. If it is necrotizing fasciitis, I'll make sure that I need to take the patient to theater. I need to inform the ITU people as well. I need to, for the anesthetist, go to theater myself and tell them, and consent the patients for relook and basically deal with the necrotizing fasciitis.
How do you diagnose it again? You told me there's how do you diagnose necrotizing fasciitis?
There is laboratory assessment of necrotizing fasciitis. I can't remember exactly the.
Okay.
There are a few markers, laboratory markers, which is.
Any imaging needed?
Sorry.
Any imaging needed?
Imaging. Sometimes it helps, but you would see like gas with the field, like with the abdominal wall, or maybe X-ray can do that, but CTs can more diagnostic. Yeah.
So you have taken that patient to theater. You've taken that patient. Talk to me. What did you do in theater, Shukla?
So in theater, as I mentioned, this has to be like, I would be like scrubbed before the patient comes into his to theater, and make sure that we do it as soon as we can. I need to excise all the dead tissue until until the healthy part of the abdominal wall, and this is one of the things. To assess the site of the stoma itself and see if that's helpful. If not, this patient might need to have a laparotomy and resiting of the stoma.
Okay. So you have excised all the unhealthy tissue around the colostomy.
Yeah.
Okay. Till you find the healthy tissue. How can you define? How can you tell that this is healthy or not healthy?
Bleeding, basically. Bleeding.
You will excise all the tissue that doesn't bleed till you find healthy bleeding tissue. And then what would you do then? Would you close it? How will you close it? It's a very large area. How will you close it?
It depends if I this will be covered with I can use it depends, because ideally I would like to arrange for a second look.
Yes.
So I would leave it open, but I would cover it with some wet swabs, or I can use the riboflavins swabs, covered with riboflavins, and arrange for a second look, basically.
For the second look. Okay. Thank you. Thank you very much.
First
of all, I have to thank you for having the courage to volunteer for that.
You're welcome.
I'm not assessing any knowledge and not judging anyone. We know that. Well,
it's all right. It's all right.
So it's just we are exercising what we have just discussed. Okay.
Absolutely,
Right.
absolutely.
Let's put what the anatomy of a question in practice here. Thanks, Checker. You can mute yourself.
Thank you.
I'll not ask you anymore. So, first of all, I gave you a presentation, someone who has some redness around the stoma, and I gave you some clues as well. I told you it's day one. Okay, that should exclude a few things. I gave you this, his diabetic. So, what should you do? First of all, you should have a scheme. You should have that's someone who's unwell. You go to the CRISP. Okay, A, B, C, D. Okay, you need to still go through that first. I want to check the airway, the breathing, the circulation cannulas. Okay, and then you go through the notes. You would like to know what they've done. Once I told you that the patient is using high, that's his situation awareness tested. All right, the patient using 9, you should call ITU. We should transfer that patient to HDU at least. The patient is on the ward. So that's an unwell patient. And then you get the sepsis 3 in, 3 out, and they give you a few clues to say that's necrotizing fasciitis. We needed some prompting, some discussion, just till the candidate says necrotizing fasciitis. As an examiner, I will never tell you necrotizing fasciitis. Only when I give up, I say, do you think that could be necrotizing fasciitis? Or your researcher is asking you, sir, could that be necrotizing fasciitis? And then you say, that's light bulb. Yes, that could be necrotizing fasciitis. When I mark that in the exam, that's extensive prompting. You will never get the full mark for that. Okay? That's extensive prompting. Even some examiners wouldn't even bother prompt you. They will go through the CT and the CT findings and this. We all know that day one post-surgery, any surgery, imaging is useless. How can you diagnose collection in a CT scan? It's free gas, it's free fluid. Someone had a laparotomy yesterday, you would expect him to have both. Okay, even the radiologist will be reluctant to do a CT scan. Actually, we all know that. Once then you go to the necrotizing fasciitis, then I will ask you about the management. Key things about the management of necrotizing fasciitis is it is purely clinical. Any rapidly progressing infection is necrotizing fasciitis. It is a clinical diagnosis. You do not do any imaging at all. Actually, if it's not post-operative, it's not post-surgical, the only accurate imaging is MRI, which is very academic. We never do it. Once you think it could be necrotizing fasciitis, you take the patient to theater. Okay? You do not try for the definitive surgery because you do not know what is the extent. You excised all the unhealthy tissue. But will that spread again? You do not plan any definitive reconstruction at this stage. That's why I wouldn't worry about reciting the stoma. I wouldn't worry about how to close that, how to reconstruct it. I'm saving the patient life. It's very important here to say I will send that specimen to microbiology urgently because I need a definitive diagnosis of my necrotizing fasciitis. Okay? Remember, so far it's all clinical. What I would do, you should just staple the stoma end and put a vac dressing, put a vac dressing or any dressing, and the patient should go to ITU. Do not wake the patient. Start him on antibiotics and plan for a relook after 48 hours. Okay? All what I've discussed is the second phase of the Viva question. That's where you get the marks. Okay? Then we go over, do you know any scores? It's the Eldrenic score that what Shikha does for, which is written here. It's not really something that we look at. It's academic more than anything. Okay, but that's what will get you to the 8 mark for that scenario. Okay. Any questions? Anyone disagrees?
I think that was very, very helpful.
Yep. I'm not discussing the neck fascia itself. Okay, it's of course and we'll go through that. You go through that either through the course or any course you will take or with your study. The most important here is to answer it. Okay, how will you answer the question itself? Because you can have a scenario about something that you don't know the answer for. believe it or not, you can still pass if you approach it the right way. And that's why I told you knowledge gaps are not the commonest cause of failure. It is how you approach it. Okay, how you think about it. I liked when Shukr started thinking out loud. There are many reasons for that patient to be septic. It could be collection, but that's too early. Wound infection, it's too early. So he's shown me to the process of thinking. Even if I wouldn't give him the full mark, probably I wouldn't fail him for that. He knows how to answer. He knows that's not that. Okay. Yeah, he's done something unnecessary. The CT scan, I wouldn't have done it, but well, at least he didn't wait. He did not say it's just wound infection, cover it and reassess it tomorrow. If he tell me that, I will tell him tomorrow half of the abdomen is red and necrotic. The patient has lost half his abdomen for that, and that's a real life scenario, by the way. That scenario is a real life, and probably I think that has came before the FRCS exam. I'm not sure, but I think so. Okay. Right.
Can I go for the second one?
Sure. You said me asking.
Yeah.
Okay, Malik.
Yes, please.
You are in the general surgery clinic. Okay. You are seeing a 76-year-old male referred to you. He's presenting with his carers by the GP for recurrent UTIs and foul-smelling frothy urine. Okay? He lives in a care home. He has dementia, but otherwise he's fit and well. Let me repeat that again. 76, referred by the GP to the general surgery clinic. You are in the clinic with his carers. He's got recurrent UTIs and foul-smelling frothy urine. How would you approach this patient? How would you assess this patient?
So first of all, this patient, I need to take the history and then probably proceed for examination. Now, if the patient is living with the, coming with his carers, and I will inquire about, I'll try to assess first of all myself. If the patient understands what's going on, I will ask these basic questions of history, like how long this is going on, and probably is there any fever, is there any change in bowel habits, is there any bleeding symptoms, like all the red flags. And if that will help me in two things. First of all, it will let me get around with my history, and secondly, I will be able to establish whether the patient has the capacity, is he having any dementia. So once I establish if patient can give me the history, I will continue. I'll quickly move to the for them. Once I've clarified my basic things, like with the history of fever, history of change in bowel habit, history of weight loss, and how long this is going on, then I will move quickly to the past medical history. So I will try to assess if there are any comorbidities, especially concentrating on his cardiopulmonary status, concentrating on his and I'll also check whether the patient is taking any medication. Here will be more important to know if the patient is on any anticoagulants, if the patient is taking any steroids, and also checking about the patient's physical fitness, how far he walks. So if the patient continues to give me history, that is well and good, and I understand that patient has some capacity. And if if there is a small possibility, if the patient lives in care home and they have dementia, then it will be entirely switched to different way, because then I don't know, and then I need to involve someone who is next of kin of this patient. So let's say if I continue and I get the history from the patient, now I need to know about the past medical background. I need to know how fit they are. So I will also need to know basic things of allergies or any previous surgeries.
Okay, so let me answer some few questions before we proceed any further with the clinical examination.
Yes, sir.
The patient is a very poor historian, I'm afraid. All the history is gathered from the carers.
Okay.
They tell you that he has hypertension, he's got AF,
Yes.
he's on rivaroxaban.
Yes.
Okay, he doesn't. He's demented. Most of the day he spends lying on his chair.
Mm-hmm.
Right? They haven't noticed any weight loss or any change in his bowel habits. No bleeding, nothing like that. But the main symptom that bothers them, that is frequency of micturition.
Okay.
It's very foul smelling,
Okay.
and sometimes it's very frothy. And one of the carers tell you, I'm not entirely sure why the GP referred me here, because I thought he would refer me to a urologist.
Okay. That's fine. So now we have assessed that in this situation, patient entirely has got no capacity. Definitely, whatever got the information, I think that's enough information for me. I will proceed for the physical examination before I get back to the certain points of decision making. I'll take the patient. I'm not sure patient can give me permission, but I will see if the patient allows me to examine. I will proceed for the. I will check the general appearance, how frail they are looking, how they move into my examination room, how they move to the couch for examination, how slow they are. That will give me a little bit idea to establish their fitness. Secondly, I will proceed for abdominal examination, check for any palpable masses. I will feel for any peritonism. Unfortunately, unlikely though, the patient who is coming to the clinic is peritonitic, but still I will try to feel if there is any discomfort while doing the examination. I'll do the rectal examination, and if they can pass any urine and there is any facility available to send for a urine sample to the lab, we'll do that. Now,
Okay.
yes.
So all clinical examination is unremarkable.
Okay, that's fine. So now I will try to establish who is this patient. This patient in this so far, I think this patient most likely, there could be many other reasons, but most likely is having a colovesical fistula. This fistula can be due to many reasons. It could be through diverticular disease, which is very common. This patient is elderly. He might be having underlying malignancy, which is getting advanced, or it could be.
What is a colovesical fistula?
So when there is a communication between the bowel and the bladder.
Okay, right.
Yeah.
And why would that cause his symptoms?
So when because patient is having frothy urine and is foully smelling, if there is an attachment, it will cause him to develop recurrent UTIs. Of course, this can be a UTI isolatedly, but that my thinking will be to rule out the first of all more sinister causes.
Okay. So how would you ascertain your diagnosis?
So now this patient, as I said, that first of all need to determine in clinic whether this patient, and I'll ask if to my staff nurse if they can kindly do the observation. I'll make sure that patient is not septic. If this patient is septic, then I need to send them to the A&E and proceed via the
A&E. The clinic, the patient is not.
So if the patient is not, yes, if the patient is not septic, then we need to arrange the urgent investigations and to get the first of all, I'll check if the GP has done some baseline bloods, including EGFR, CRP, and white cell counts and stuff. If the EGFR is fine, then I'll proceed for urgent CT abdominopelvis with IV contrast.
CT abdominopelvis with IV contrast.
Yeah, and then also, as I said,
what would that show?
So it can show any, intra-abdominal masses. It can definitely tell me if there is any, though the CT will be without, oral or lower rectal contrast, but it still can show the possibility.
How would you request the CT? Do you want it with oral contrast, with rectal contrast? How do you want it?
No, I will proceed for the CT with IV contrast in the first instance. Okay. It can still show that if there is any air in the, bladder, and if the loss of fat planes between the bowel and it can still show the possibility of the diagnosis.
What's the commonest cause of air in the bowel, in the bladder?
So it could be the fistula, could be the bladder intervention that has been recently done. The
patient has got dementia. You would expect him to come with a urine catheter, which he has. Could that show?
Yes. Sorry. What did you say?
The patient has a urine catheter.
Yeah, that's one of the possibilities. That's what I said is that if there is an intervention done by the urologist.
If you find a bubble of air in the bladder, that wouldn't be very specific malic, would it?
Yeah. It will. Yeah.
So will the CT tell you if the cause of the fistula is malignant or due to diverticular disease?
So that's a very tricky one. Though CT helps to see, and further patient will need a camera examination in terms of a flexible sigmoidoscopy or a colonoscopy, of course.
Flexible sigmoidoscopy or a colonoscopy.
Yeah.
Right. Okay. So You had requested a flexible sigmoidoscopy. The patient is coming to see you with the results. The flexible sigmoidoscopy confirmed that it is colovesical fistula, as you suggested, due to diverticular disease. What
Okay.
would be the plan of management?
So now, as I said, that in this patient, technically, if the patient needs to have a procedure which could be which can be done or the laparoscopically open in terms of it could be
What procedure
Hartman's.
would that
So
be?
it could it's most likely it's going to be Hartman's procedure. So we
Hartmann's
need to,
procedure.
yeah, most likely. Then there are some like if I am doing this procedure, I'll be safe doing safely, doing the Hartmann procedure. But in this scenario, I think we also need to get the help from the urology to see, I will get a bit more in before. Basically, let me go back to before discussing this, booking this patient for procedure. I will also would like to run this case to the regional MDT of colorectal, because not all the diverticular disease reported by the CT scan or all the divertic, it could be malignancy inside. And then the other thing is that I will get a bit more information about the involvement of the surrounding structure, because here there are a couple of things going near, especially ureter, and it could be the involvement, and then I need the help from my urology colleague as
You're
well.
colorectal malic, aren't you?
Yes, I am.
Okay, right. So the patient's coming to see you with a follow-up.
Yeah.
When he comes, he's got his son with him.
Yes.
Okay, and you are explaining the operation to his son. Talk to me, how would you do that? So explain to him, what will you do?
So if we have decided that we are going for the procedure and we agreed that patient is fit to proceed, I will explain, and of course I will let them know about the,
I'm the son. Explain it to me.
So as a colorectal surgeon, my first approach will be to proceed with the laparoscope.
What's the laparoscope?
So I will tell them that I will be doing the keyhole surgery. This is with the help of camera, where we make a couple of holes in the abdomen and try to proceed and remove the part that is diseased. And then probably your father is going to end up with the and stoma, which is forever. I don't think but
Sorry,
most likely.
stoma, I haven't heard of that before. What is a
So
stoma?
sorry. Yeah, this is a bag that is a temporary. That is a bag that we put on the skin of the patient, where the poo will be diverted. That will remove the attachment of the bowel for your father from the bladder, and also we will do the repair of the bladder with the help of our urology team, and hopefully that will obliterate the hole that your father is passing
I'm sorry. Are you saying that my father will poo through his abdomen forever?
Yes, that's
So
the most.
why can't you just take that out and join it back again?
So in this situation, I'm afraid your father has got many underlying medical problems, and there is a high risk of leakage especially in the left-sided surgeries when we do the sigmoid. When we do the left part of the bowel, and if we try to rejoin, the risk of leakage of that joint goes around 20%. So
what's wrong with my father? Why is he more likely to leak than me, for example?
First of all, if because this is an inflammatory area, and it will be tissues will be inflamed, and joining the inflamed tissue, there is a high risk of leakage.
Is that your usual approach with these cases, doctor? So any patient with this abnormal connection between the bowel and the bladder, is that the operation will do for them?
So yes, most of them, not all. As I said, I am putting the in this context, especially your father giving his past medical history, and
my father doesn't have anything. You keep saying past medical history, and he doesn't have any past medical history.
So he has AF, and he's on adoxaban.
Yeah.
And
I have that too, but that's not an issue, is it? Is that would that be, how can that increase his risk of leaking?
So that does not increase, definitely in his case. That does not increase the risk of leaking, and technically you are right. But what I'm suggesting is that I feel that this is the safest approach for your father.
Okay, but I think that would negatively impact his quality of life. Don't you think so, doctor?
Yes, I at some sort I agree with that, because he has had dementia, and then we need to think about that, how is gonna manage his bag, but I think the risk of leak is high as well. So my
So
brother.
if he goes for that operation and it all goes well, fingers crossed, can you join it back again?
Yes, that is a possibility, but I'm not sure entirely. Depends on how he goes with this operation, and then if he's well enough and have another operation. But still, that operation is too risky as well.
So if you think that there is a risk, can we just leave it like this? What would happen? He has been
So
like this, I think, for the last 2 years.
So that was the other aspect of the operation I wanted, of this scenario. I wanted to talk to you about your father. That there is a small possibility that we leave as it is, but that will be causing him recurrent, like a repeated infection of his urinary tract, which of course can lead to sepsis and can be very serious.
Okay, okay. Thanks, Malik. You mentioned something about his capacity and examining him. Do you know what other types of consent?
So, of course, consent form one, which we do for the orange one, that we do in NHS for every patient who has got the capacity. Then there is a consent form two, which is probably for the, if I exactly, yeah, it's for the children where the parents sign. Then what one I don't know, I just, it's a little skip from my mind, but this consent form four, that we where the healthcare provider make the decision giving the
Well,
safety of the patient.
consent form 3 is for local anesthetic cases.
Yeah, that's for local.
But that's not my question, actually.
Yeah.
My question, you mentioned that you would like to consent the patient before examining him. What type of consent would you take of these patients?
So these are the verbal consent.
Verbal consent.
Yeah,
So there is a
that's
written consent. There is a verbal consent. What's the third type?
Written, verbal. I'm not sure. Sorry.
Anyone knows? Anyone else?
Informed consent.
Implied consent.
Implied consent.
Implied consent. Thank you very much, Malik. Thanks. That was I have not been easy on you, I have to admit. Okay, right. Let's go through that. This is a scenario of a colovacycle fistula in an elective case. Usually, if you get something like this, that would be, we haven't taken a lot of time, by the way, that would be something like a long clinical scenario. Okay, so ideally that should take around 20 minutes.
Mm-hmm. Yes.
So, and that's fine. So again, the approach for that should be the same. We have to go that very slowly. You have to understand what is the setting. Is it elective or emergency? You've done that very well. And then what should you look for? And as I told you, I will never give you a diagnosis. You tell me, oh, that could be a colovacycle fistula.
Yes.
Okay? And then we go from there. It's a patient without a capacity, and you have to differentiate between the patient without a capacity and the patient who is unwell. There is a patient, so that patient has just got AF, but he's got dementia. He's nursed and he's on the chair most of the time, which you can tell probably he's got he's looked after by full-time carers. Okay. With the management, so the first part of the Viva, as you said, we will go through the history, examination, clinical. With the history, I need to know that what are you looking for? Okay, you're not just asking a random question, because I can stop you at any point and tell you why you're asking about that. What's the significance of asking about that? Then once you said, I'll ask you about the management. The management usually with colovacycle fistula does not start with a CT. It starts with a flexible sigmoidoscopy. Okay, that patient, it might be very hard to do colonoscopy for him. I'm just a simple breast surgeon. You tell me you're the colorectal expert, but with the bowel prep, it would be very hard. Okay, you can do one of two things. You have to start with a flexible sigmoidoscopy, or you can do CT with CT colonoscopy, virtual colonoscopy.
Mm-hmm.
And that would show you if it's just diverticular disease or if it is cancer. So the first thing, you have to assess if the patient is fit to have bowel prep or not. If not, you have to consider either flexible sigmoidoscopy to start with, or if you'd like to do a CT scan, CT colonoscopy. Yes, as I told you, CT would be less sensitive here. It can show you a very large abdominal mass, but if you are in the colorectal rapid access clinic and you got someone with a change of bowel habit, you wouldn't do a CT for him, Malik. You would do a virtual colonoscopy or a flexible or a colonoscopy. Am I right? So CT would not be that sensitive, and especially when I told you that you told me that you can see gas in the bladder, which I agree. But someone who has full-time care most probably has got a urine catheter, so you would expect to find gas in the bladder anyway. Okay, then it goes to the management. I agree with you with the option, with what you offered the patient, but I do not agree for the reasoning for that. Okay?
I did myself. I realized that.
Yeah.
I realized that.
WN, you have a question?
Hi. Yeah. So before going to the management,
Yes.
do we need to do a flexible cystoscopy, given that the patient he had 2-year history of the symptoms? So that's mean he had the 2-year he's having colobasal fistula, and that brought him to might be develop bladder TCC, and we need a biopsy.
So that's another thing with the situational awareness. I wouldn't go for a cystoscopy. I would say you have to discuss with a urologist. Involve a urologist here. Okay? With the situational awareness as well, I need to ascertain who has got power of attorney for this patient. These are the simple things that are not related to the knowledge, but are related to your approach to the case. I need to know who has got power of attorney. I think we all understand what is power of attorney, isn't it? Yes, for us.
It's a very nice discussion. This patient is almost home care patient, and this patient is not mobile at all. So there is a huge question mark about the patient's fitness to go into surgery, bowel resection, and laparoscopic approach will take a long time.
I'll go to that. I'll go to that shortly with the management for us. We're still in the diagnosis bit.
Yeah.
I agree with you, but as I told you, for a different reason. Sorry to interrupt you. I just didn't want to interrupt the flow of thoughts. That's the thing. What were we talking about? Yes. So with the situational awareness at this bit, I need to know who will make the decisions for this patient. Definitely the patient does not have a capacity. Who has got power of attorney for this patient? You need to say these things in the exam. Okay. You need to see the patient has been seeing the GP for 2 years for recurrent UTIs. Maybe he has seen already the urologist. If not, you have to discuss with the urologist. It's nice what Malik mentioned, that he will bring that to the MDT. Maybe you can discuss it with the urologist at that point. Maybe he would say, no, thanks, we don't need to. But that's a very good point. But your key thing to say, is it diverticular or is it cancer? You need to do either a CT colonoscopy or a flexible sigmoidoscopy. Someone who is not that fit, you would rarely go for the bowel prep for a colonoscopy, for a full colonoscopy. And if you want a CT anyway, why not doing it as a CT colonoscopy? Okay, so that's how we diagnose it. Let's go to the management. What you offered. Malik offered him Hartmann's procedure. I agree. He offered him that because of the high risk of leak. I disagree. Okay, it's mainly for one reason, Malik. Why bother? First of all, the patient just if that patient, what do you think the ASA for this patient?
3 minimum.
SA3, why? Is SA 1 or 2 maximum? He just has AF, which is controlled. Why 3? The patient is fit and well. That's the thing. You have to differentiate between frailty and being unfit. The patient is frail. He's not unfit. He's got dementia. That does not add any risk to his anesthetic. He's SA1 or SA2, actually. He's SA2. You can call her his SA2. So he's not high risk at all. He's not even 3. I would call him as SA2. It's just a well-controlled chronic disease, isn't it? Okay. So that's for a different reason. The patient does not have any higher risk of leak. The question is, why do you take the risk of leak at all if the patient will end up cared for full-time, possibly wearing a diaper? The patient will be wearing a diaper anyway, full-time, because he's bedridden. Actually, it will be easier for him to have a stoma bag. So when I ask you, will that affect his quality of life? The answer would be no, it will not. There is nothing that he is doing that I would stop him from doing after the operation. Even if the patient, even if you do high anterior resection for this patient, which is usually either sigmoid colectomy or high anterior resection for this patient, that's the usual approach for this. Whether you do as a 1-stage or 2-stage, that's your decision for your patients, Malik. Most of the colorectal surgeons I do them, they can do it easily as a 1-stage. They can do a covering loop ileotomy or not. Okay, but they didn't do as a 2-stage Hartmann, then reverse it. That's why I know. But as I told you, I'm not a colorectal surgeon. But there is no reason not to do it like this. The thing is, why take that risk if it's not going to improve his quality of life? And that's how you should approach that in the exam. You should explain to the patient, or to the son in this case, that there is usually, we can join it either this stage or at a later stage, but it would not add any benefit to his quality of life. Actually, you're taking a risk of having a leak and going into sepsis without this reflected into any improvement in the quality of life for the patient. That's the reason. Anyone disagrees?
No, I think these are the things we need to, let's say if we are doing in the clinic, we do these things, but yes, you are right. These things should be told to the examiner, because otherwise he will not know that I know these things.
Yes,
you are right.
That's why I told you. You have done the right choice. It's the right decision, but for the wrong reasons.
Yeah, you're right.
Okay, and then it's about how will you say in this scenario that you would offer that to the patient. The patient says no. Well, I would like it to be joined at the same. Remember, as a candidate, I'm not asking you to tell me what's your executive decision. Is it yes or no? Right? I'm asking you to explain to me why you say no. And that's a very important concept. And again, that's one of the things about the senior surgeon syndrome. I think that was I told you before. We find that in very experienced surgeons. You tell to the patient, so you tell the patient you will need a Hartmann. The patient tell you, but I want a high anterior. You say to him, no, I think the best for you is a Hartmann. That's not the right answer. That's not the right way to answer that in the exam. Okay? The right way is Hartmann is better than you, because then you're not going through the risk of leak. Okay? And then that risk will not be translated into any better quality of life for you. Okay? That's one thing. And then when you consent the patient, Malik, probably you noted that yourself, I had to stop you 1 or 2 times. I'm a kind examiner. Not everyone is like me. Okay, some examiners will just cancel marks. You do not say endoscope to consent the patient. You do not say a laparoscope. You do not say a stoma. Okay, these are all medical jargon. That's why, and that's a common pitfall. There is no one whom I gave him this scenario and didn't fall into this. But these are the things that you need to be mindful for when you're studying it and when you're getting yourself ready for the exam, because you will lose marks for this. Anyone who has failed the exam before, they can ask for a detailed feedback. Okay? And I have seen few detailed feedbacks before. In the detailed feedback, it's like a handwritten sheet with the examiner say, why did I fail him in that station? And you will find most of them, they use a medical jargon during consenting. It's a very basic and massive thing, but believe it or not, you lose a lot of marks. Okay, and then it goes to the higher things about consenting. When I asked you what other types of consenting, implied consent, there's other things, implied consent, verbal consent, and consent. And I would go further if I got the time to assess how do you assess the mental capacity of the patient, right? How can you take the decision in the best interest of the patient? These are all things that I would go further. Then that's a very nice 5er. Okay, any questions?
No, thank you very much. I think that was really very nice, structured feedback. This things help to rectify the mistakes that we can make before the exam, not in the exam.
Yes, 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 exactly. And that's why I keep telling everyone, knowledge gaps are not the commonest cause of failure. Believe me. Okay.
Yeah, you're right.
It's about your approach and how to manage the stress during the exam. Okay.
Thank you.
You're welcome. Any volunteers for the? We'll just go for 3 scenarios today.
I can take the
Good. Well done, Frost. Okay, Frost. You are in the general surgery clinic. Oh, sorry. You are in the SAE. You have been referred a male patient who is very concerned, as this morning he has got pain in both his breasts and he has some swelling in his breast as well. Can you explain to me what you can see here?
So based on this picture, I can see the patient has a gynecomastia, degree of gynecomastia more on the right breast more than the left. I cannot see any.
What is gynecomastia for us?
So gynecomastia, it is an abnormal shape of the male breast that is causing fat accumulation around the nipple areolar complex, and it could be sometimes more of aesthetic shape, sorry, like a female breast.
How would you assess this patient?
So this patient having gynecomastia itself is not a problem, but if the patient has pain in both breasts, that is here the problem. And this patient will be, of course, will take a proper history, detailed history of any medications. Sometimes could be long-term use of some medications can cause side effect gynecomastia. Or,
like what?
Like Brantidine, as I remember, I think cimetidine, and actually it's a long list of medications. I cannot just.
I know it's a long list. I'm asking you about it.
Yeah, yeah.
Just mention 5 more, and that's it.
Okay, 5 more. Okay. I think aldosterone. And
okay. What are the two? What the commonest 3 you haven't said yet? Just 3. I'm giving you a count now. Okay, just the commonest 3. You haven't said the commonest 3 are spironolactone, of course.
Yeah, spironolactone, yes.
Of course. What else? Second one, digoxin.
Digoxin, yes, that's
and hormonal treatment for prostate cancer.
Yeah, the hormonal ablation. That's right.
Okay. What are other causes of gynecomastia other than drugs?
Hormonal imbalance.
Like what?
Like could be sometimes could be, I'm just trying to remember. Sorry.
Okay, don't worry. That's fine. We'll go to that later. How will you manage this patient?
So I will assess the patient, taking history as said, and we'll do a clinical examination, checking the breast, both breasts, if there is any redness or any warmth on touch, and assess the axillary lymph nodes. We'll do some blood tests on this patient, including the hormonal level.
So what blood test will you do for this patient?
So we'll do the basic surgical blood test, like full blood count, liver functions and renal functions, U's and D's, CRP, and we'll test the patient's testosterone and the progesterone, and estrogen as well.
Okay.
Yeah.
What else? Any other medications?
Medications.
Any other investigation? Blood investigations. I'm sorry.
So the basic bloods, the hormonal bloods, and I can test the patient for any.
You said hormonal. Any other hormonal you need to test?
Anabolic steroids can be causing that.
Okay.
Yeah.
Okay. Any other? What else? Any other imaging? Any other scans?
We'll refer the patient for ultrasound scan of the breast, and we'll check for if there is any lesions underneath within the breast. And yeah, that will be the
So
initial
what imaging will you request? Sorry, I missed that.
ultrasound.
Ultrasound of the breast.
Yes.
Anything else?
Uh,
Can you do sorry? Can you do a mammogram?
it is technically difficult for a male patient because it needs to be compressing the breast between the boards for the mammogram. It is technically difficult.
Okay. So you never do a mammogram for a male?
Yeah.
Okay. Right. We have done all the imaging. It confirmed that it is gynecomastia. What would be the management for this patient?
So for patients, the management of the gynecomastia itself, it depends if it is caused as a side effect for the medications, as we mentioned, if the patient is taking ranitidine or taking hormonal therapy, or patients having lifestyle like such as smoking marijuana or some of these materials. So to modify this, and that will be helpful to stop happening. I mean, stop occurring the gynecomastia. If the patient is having, based on the blood test, is having liver disease or kidney disease, or also we can investigate for some other issues like a thyroid, or if there's any cancer, sometimes can be causing that. So yeah, this is how we should investigate for gynecomastia.
Okay, right. No, I mean the treatment. So that's how you treat it. The patient is asking, well, that's very embarrassing. Can we do surgery for it?
It depends on the grade of gynecomastia.
What are the grades of gynecomastia?
Okay, I'm trying to remember the name of the grading, but it is 4 grades. Grade 1, which is just simple protruding of the nipples. Grade 2, slightly bigger, but there is no dangling of the breast. And yeah, I'm just trying to remember that.
You know what is the name of that classification? It's okay, that's fine. Last question. The patient is asking you, doctor, can that cause cancer?
No.
So that wouldn't turn into cancer in the future?
Gynecomastia itself is unlikely to cause a cancer.
Okay.
They are consequence of a cancer.
Sorry, they are consequence of a cancer?
It could be caused by cancer.
Which cancer?
So sometimes testicular cancer or lung cancer, or some pituitary gland tumors can cause gynecomastia. But
so that patient could have gynecomastia due to testicular cancer, right? But you have never tested him for that for us.
Sorry?
That patient could have a gynecomastia as a symptom for testicular cancer, right?
No, it's not symptoms. It's as a consequence. The patient is having...
As a consequence of testicular cancer?
After taking the hormonal therapy.
Oh, it's just after the hormonal therapy. Okay. Or pituitary adenoma. But I have never tested him for pituitary adenoma, have you?
I can investigate that. I can investigate that.
It's fine. Thanks, Frost.
Thank you.
Sorry to take the mic out of you. Right. Okay. As I said, we're not judging. We're not. You haven't even started studying. Yeah, that's why. That's a third type of scenarios or topics that you can get in the exam. Unfortunately, breast is very famous for this. Okay. Breast, especially, is you know it or you don't know it. Okay, you cannot guess. By the way, gynecomastia is a very, 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 very common theme for general trainees as a short clinical case. In the general trainees, they don't bring it to the breast trainees because that's too easy for the breast trainees. Okay, they bring it usually to the general trainees. Is as a short Viva or as a short clinical. The issue is, as I told you, you either know the answer and you get the full mark, or you don't know it at all, and you cannot guess. You cannot guess the answer. It's not like upper GI, colorectal. Whatever your specialty, you are a general surgery registrar. You do emergency room calls. You see lots of colorectal cases, even if you're not colorectal. You see loads of perforated peptic ulcers, even if you're not an upper GI. But you do not see lots of breast. So with breast, you either know the answer or not. Gynecomastia is a very common. Let me just try to show you something. Let me know if you can see my screen. Can you see it? Yes? Anyone tell me?
Yes, we can see it.
Yeah,
Yes.
we can see.
Right, okay. This is the ABS guidelines. We'll talk about this later. These are the causes of gynecomastia. The issue is you see, oh, that's liver test, thyrotoxicosis, acromegaly can cause that, drugs like that and that and that. Testicular cancer can cause, not just the treatment of testicular cancer, the testicular cancer itself can present with gynecomastia. Okay, liver cancer can present with that. Okay, it could be physiological. Okay, that's when you need to do all these investigations: testosterone, thyroid function test, liver function test, alpha fetoprotein, beta HCG. Okay, and you need to do testicular examination. And if testicular examination is abnormal, you need to refer to the urology clinic, or you can consider testicular ultrasound. That's from the ABS. Okay, that's the issue. So you either it's if you go to the ABS, associated breast surgery, it's free to everyone, and you go to the clinical guidelines and you look for gynecomastia, you will find it. Okay, it's the thing when you go through all drugs. In the exam, they ask specifically about it. What drugs? Which of that? What? And when you go to the investigation, because that's very common thing, oh, that's a very long list, every blood test. No, we need to know what every blood test. You need to know what are you looking for, because gynecomastia on its own is nothing. It's nothing that we need to treat. We do not do surgery for gynecomastia. It's not funded by the NHS. Okay, because that's purely cosmetic procedure. But what you do not want to miss, you do not want to miss the gynecomastia as a symptom of a more sinister disease. Something like, you do not want to miss a testicular cancer presenting only with gynecomastia. You do not want to miss a liver cancer presenting only with gynecomastia. So you need to go for all that. And yes, for us, we can do mammograms for men. We have women whose breast is smaller than this, and we can still do mammogram. So yes, you can do mammogram for men. But again, it's something you either know or you don't know. And that's that's probably the tricky thing about the breast. Over the last few exams, they used to bring the long clinical case for general trainees as a breast case, which, if you don't imagine how many marks you have lost. Okay, so that's a different one. That's a different type of scenario that you can approach during the exam, when it's, as I said, there is no hierarchy. It's either you know it or you don't. Okay, any question? Yes, Mohammed. Mohammed, you're muted. I don't know what it is.
Yeah, I'm just want to ask, for, let's say, gynecomastia, they will ask about etiology and workup. If you reach this, how deep you must know? Or
What do you mean? So the thing about gynecomastia,
technical operation you don't offer, or just the basics?
so what you need to do, you need to know everything about gynecomastia. The topic of gynecomastia you need to know. That if I ask you one advanced question, would be about the classification. When I ask about it, what are the classification of gynecomastia? It's called Simon classification. Okay, that one he said. What do you need to do? You need to know, because there is no treatment for gynecomastia. We do not treat it. Okay, it's all about the etiology. It's all about the workup. Okay, it's all about the imaging and any investigation. Okay, it's all about knowing as well, assuring that gynecomastia is not a predisposing factor for male breast cancer. So it's not. You need to know everything about gynecomastia.
Fine. If we went into breast cancer, patient or lung case, I assist her triple assessment with diagnosis. Will they go more further operative approach or for a general surgery?
No. There are things that you should know. There are things that you do not need to know. Okay. So you need to know what option. It's breast surgery, especially. It's
Just
now. Sorry.
can like to have auxiliary dissection or sentinel biopsy or something I have to do.
Breast surgery, especially, Muhammad, is very complex. Okay, and that's why in the top, I'm going to speak about the course now. Because I'm responsible for the breast portfolio for the trainees in the course.
Yeah.
I give 9-hour lecture about it. It's not because you need to know everything. The most important bit in the breast is what you do not need to know.
Exactly.
Okay.
If I want to prepare a breast, should I know as
I know what you mean. No, I get what you mean. No, there are things that you need to know, and in the course that someone should tell you what you need to know and what you do not need to know, and that would be in your curriculum as well. What's an ST4 level? What's not an ST4 level? I will give you an example, Mohammed. That's just an example. You need to know that if the patient's got positive lymph node from the start, you need to do axillary node clearance. Okay, if the axillary lymph node is negative from the start, you need to know sentinel lymph node biopsy. Okay, and if the sentinel lymph node biopsy is negative, you do nothing. Okay.
They will not ask me, you have one sentinel lymph node out of three.
Hold on, Mohammed. Do you want to know what the breast trainees should know about the axilla?
No, just asking.
That's the management of the axilla for breast trainees. Definitely, you don't need to know all that.
Thank you.
Okay, if that's your question.
Yeah.
Okay. No, I think that's very important. I will come to that shortly. It's very important, rather than to know what you need to know, it's very important to know what you do not need to know.
This how we have to know this apply for surgery. We are a little bit away from it.
Yes. So you need to know exactly what is ST4 level, so that you, as non-breast trainee, what you should know. That applies to everything else. Applies to transplant, to HBB, to upper GI as well.
Thank you.
Okay. Any other questions? Right. Okay. So we've spoken about the exam, or we've spoken about the Viva and what to expect. Now I'm just be more focused talking about our course, which is the 9th one that we're going to start on 23rd of February. How will that be done? It's different. I think it's a different experience to any other, and we all have taken courses everywhere else, and we know how is it done. So think of it like it's a mentorship program, because that's why we had always thought about we have to limit the number of candidates, as we have to assess every single candidate and their progression throughout 3 months. It takes 3 months, as you could see. Okay, it starts in February, it ends in May. If you follow that, we think that would be more than enough to prepare. 3 months are enough, assuming that you got the basic knowledge, which you have as you pass part 1. Okay. We do the scheme, we do the curriculum. So we go for a one topic every week, and the way we do that, we have developed over years of trial and error and working with different candidates. Okay. So how will it work? For a week, you will have, let's say you are doing the breast week. This week is the breast week. You will have either a lecture or 2, depends on the topic. So if the breast, you will have 2 lectures. A lecture on Tuesday, for example, that will start usually around 6 p.m. That would take about till 10 or 11 or whatever. Some topics take less than that. Some topics, they take more than lecture. For the breast, I do another lecture, which is Thursday. Breast is special for 2 reasons. For breast trainees, because they need to know lots. Breast trainees, they need to know. Trial for breast trainees is not just to get the full mark. Trials for breast trainees is the bread and butter of the question. And for the general trainees, that's even harder, because from my experience, I'm expecting the general trainees to know nothing about breast. So that's why we developed these lectures. So you will have a lecture Tuesday that would take about 3-4 hours. You have a lecture Thursday that would take about 4 or 5 hours. It will be just passive listener to that. Okay. And then when it comes to the weekend for that week, you will have Saturday and Sunday. Saturday, the morning, will be Viva for 2 or 3 hours just for the breast trainees, for the specialty trainees, and evening from 6 p.m. till 8 or 9 p.m., that would be for the general trainees. No lectures, there is no talk, it's just Vivas, okay? And this, that we call learn by doing. You have the knowledge through the lectures. You will only learn how to answer the Viva, not by lectures. It's by doing it, by doing mistakes, by watching others doing it. Like today, I am sure that most of you who did not answer, they learned a lot just by watching Faraz, Shukr, and Osama answering this Viva, even if you did not answer this yourself, okay? And that's why in the course itself, we do that through Teams, or through Google Meet. We have to ask you to keep the camera on while you're answering, if not all the time, because I need to assess your body language. I need to assess the quality of your response. I need to put you under stress, okay? If you think that answering a question that you do not know while you are at your own home, just sitting and staring at your laptop is a stressful situation, wait till you see the exam, okay? And that's why you get gradually desensitized to that stress. By the time you go for the exam itself, it's just another Viva, okay? We communicate through you, as I told you, you get the Vivas with the constructive feedback that seemed like we have done that today, all through Saturday and Sunday. For the specialty trainees, whatever your specialty, you will do that in the morning for your week. You do not need to attend the evening. If you're a general trainee, do you need to attend the specialty? You do not need to, okay? You can if you want, but will not attend that live. All these lectures, all these Vivas are recorded, and you can go to that later. So if you're not a breast trainee and you would like to have access to the breast specialty discussion on Vivas, you will not do that live. It just will cause more disruptions to the trainees, okay? Because they're being questioned for a different level. But we're not hiding that from you. You can access that through later into the recorded lectures, okay? And that's how it's done. We communicate with the trainee through 2 different platforms. The first one is WhatsApp. Okay, WhatsApp are on. We do not discuss any questions. We do not answer anything. Are only for general discussions, course announcements, or for just logistical things. But the actual discussion goes on Telegram, and that's for a reason. Okay, the Telegram is more protected environment. We can control that. Nothing. All the information there are protected. Nothing could be taken as a screenshot. You can copy from it. All that, and that's very important to protect our effort and your investment as well, okay? It is a huge investment, that course. We compared to others, which are 3 or 4 days, that's more hours, and we'll come to that later. So you need, and that's more expensive, and we know that, but we want to protect that. You will have a library, and then we'll go to that later, okay? So what to expect What not to expect, sorry, spoon feeding the knowledge. We will not tell you this is how to answer that question. This is the ideal answer to that question. Because there is nothing. We will answer, we will try to help you to how to answer any question, how to approach that. Okay. And that's what you do in real life, isn't it? You approach some difficult cases that you do not know what is the diagnosis for. But in your life, in your mind, you've got a plan what you're going to do to reach the diagnosis. We will not falsely reassure you. And that thing we pride ourselves. If you're a candidate, you will get regular feedback. Okay. And sometimes we do that all the time. We get 2 or 3 candidates, tell them like a month before the exam, look, you're not ready for the exam. If you would like to sit for it, that's fine, but that's our honest assessment. Okay. Do not expect that we will cover everything. There is no such thing as an everything. There is always an unexpected question in the exam. No one can promise that they will cover everything. Okay. So that's how it's done. A week is a topic, 2 lectures, and then Viva over the weekend, and you'll get constructive feedback during that, just immediately after. Okay. How to get the most out of it? How to prepare yourself to pass the exam? First of all, you need to start when we start. Okay. Is 3 months enough? Yes, but it's barely enough. Don't wait till it's late. Okay. Especially that you do not want to keep discussing the HPB when we have discussed that 2 or 3 weeks ago. Okay. As I always say, preparing for the FRCS exam is not something you do in your spare time. It's something that you spare time to do. Okay. You do not finish your work, finish your shift, and then go home, have your dinner, stay a bit with your children and your wife, and then half an hour before you go to sleep, study for the FRCS exam. That's not how it works. Okay, you don't do that in your spare time. What you do is, my advice is, you finish your work, you stay about an hour or an hour and a half every day in the library of your hospital before going home, as if you finished an hour later. And then that, with that commitment, you can pass. Okay. The Telegram group is very important. The Telegram, we do not just use that to receive your questions and answer it. Actually, we will use that to post questions all the time. If you're in that Telegram group, you will always find, look, you got a patient who has that, how will you answer that? You have to engage, because what you learn is not the knowledge. What you learn is how to answer, which is, as I said, it's more important. If you got a question in the Telegram, you don't know the answer for, go find the answer and write it. That's how you will learn. And by the time after the exam, most of the candidates who say, we had these questions, we don't tell them that you had that in the course. We give them screenshots from the Telegram. Look, that was discussed there. And that will, at the end, when you come to revise, that will act as a great Q bank for you. So you need to engage, because that's your opportunity to have assessment, to have someone to give you a feedback. People pay for that. You've got that already. So make the best use of it. Okay. Form a study group. That's very important. Do not walk that journey on your own. Find someone who can do that with you. You can support each other. It doesn't have to be your specialty, by the way. Okay, because most of the things that you will go together would be just general surgery and other specialties, and you're assessing each other when you are just practicing with each other for the Viva techniques, not just the knowledge and anything. And believe me, when you hear a question and say, oh, how will answer that? Oh, that's easy. I will do that. I will do that. I will do that in your head. Try to say that out loud. You will be surprised. You will miss loads of points. So if you think in your head, I know the answer for that question, give it a go and try to answer it in front of someone. And you'll be surprised how much things you will miss. Okay? For the group, you've got at least 2 or 3 mentors from every specialty. You do not need to go to ask your peer for that. And most importantly, we do not claim as mentors that we are the best in what we do. We do not teach you, I'm a breast surgeon, I do not teach you breast surgery. I will teach you breast surgery for the exam. So I give that most of the time when the candidates ask me, oh, Mina, what do you think we should do? If you got that scenario in the exam, how will you answer it? And my answer would be, don't worry, you will not get that in the exam. You don't need to know about it. And that's very relevant to the general trainees when they keep asking me, do we need to know about the Amherst trial? No. Or what is TAD? Rather than answering what is said, I told them, you don't need to know about it. So you've got mentors who are focused on the exam rather than the specialty. Make the most of them, okay? You can review your answers, which is very important as well. Go to the videos, everything will be recorded. Go back again and watch yourself answering, and you can reflect on that. That's how you learn, okay? You've got access to more than 100 hours of Vivas, okay? What we'll do, we'll give a blunt feedback. We are all grown-ups, okay? We do not try to sugarcoat things. If you answer something and I told you your answer is not great, Elton, I think you will fail in that if you answer it like this. And we are sorry, but we had that before. We do not sugarcoat things. If there's a better answer, we'll tell you about it. That okay? We will always grade you the same way the exam is graded. Okay? Small groups, we strive hard. We say no to a lot. We sometimes even with the Vivas over the weekend, we do the over 4 or 5 rooms just to make sure that there are small groups and that everyone participates in the Viva. You do not go join the Viva to watch. You there to practice, which is very important. Okay. Mock exams, I'll come to that shortly. This is how we grade you after the mock exams. We say who the faculty is, the name, and how we overall give you Viva performance. What is about that? What is about knowledge? What's the quality of response? Which is the same way that's you get graded in the exam. And we put comments like what especially you need to do. And you would only help me to grade you as much as you engage. The more you engage, the more I will be able to read you and tell you about your weaknesses so that you can address them early. Okay? You will get monthly report as well, and it will look something like this. And that's very important to give you insight about your weaknesses very early, and it will help you to monitor your progression. The more you work on yourself, it will tell you, look, you have done well on that, you need to do better in that, you need to do better in that. Mock test, we mark the mock Viva test, and unfortunately we got feedbacks in the past that our marking for the mock is very aggressive, and it is a charge that we do not deny. Okay, when we go for the mock test at the end before the exam, which is about 2 or 3 weeks before the exam, we will give you the lowest mark you will get if you have been assessed by the hardest examiner. So you can get a better mark, but you wouldn't get a lower mark. And we think that works in your favor. Okay, I will show you how it's more time. Of course, after you finish that's the course, probably that's the only one, I'm not sure about that. I would like to claim that that is accredited by the Royal College of Surgeons of Edinburgh, and you will get CPD hours. And by the way, that will be marked not by the whole hours of the course, but the hours that you attend. Everyone will be marked when he will log in, when he will log out, and you have to engage by opening the camera, and we'll give you a certificate for just these hours. It will look something like this. Okay, and we'll give you a certificate of attendance as well with the CPD hours that you can use for your appraisal or for your portfolio or for whatever. Okay, this would be the curriculum for the whole course. It would be look something like this. We're going to start with general surgery. It will be Saturday and Sunday. This is just for the Vivas, not for the lectures, by the way. Okay. Then critical care, trauma and emergency. That's over the weekend. Then upper GI. That's for the trainees. Usually for the trainees are in the morning when it comes to specialties, and non-trainees are in the evening. Same for breast surgery. For special reasons, not related to me, not related to the trainees, related to this topic itself of breast surgery, I usually end up giving a third session, just because it's very. Has anyone seen a breast surgery? What they should know? They need to know everything about oncology, everything. You will feel very lucky once we go through the breast that you're not a breast trainee. Then we go to HBB, academic and statistics, colorectal transplant, endocrine, and these are the mock exams. If you're going to participate, you need to know that from the start, for a very important reason. Now is the time to do your swabs, okay? If you're on call over the weekend, at least, first of all, try not to miss any of that. You paid for that. Even if you can go and watch this later, which you can, it's not the same as participating in being assessed. And definitely do not miss your specialty weekend. I told you your specialty is almost 50% of your exam. So for you, you missed about 50% of the benefit that you get from the course. If you're a breast trainee and you know that the breast is 22nd, 23rd that weekend, if you're on call, swab it. Swab it now. Okay? Now is the time to do that. Please do not miss it. Watching it later on is not the same as actively engaging and participating. The lectures. It took us a while just to introduce these lectures. It's not a lecture that I know some other courses how they do it. It's not like half an hour or an hour when you go through things. If you note this, we go for the breast surgery, for example. That's the last course. We took about 9 hours speak about breast. There are 2 lectures for esophagogastric and upper GI. Statistics, there are 2 as well. HBB, there are 2. Transplants, you got 1 lecture. Colorectal, you got 3 lectures, actually. That's because you need ST6 knowledge, endocrine. And we've got, as I told you, because you will almost always get a CT or MRI, something like that to read, we've got a dedicated lecture just for radiology. How to comment on things like a mammogram, an MRI, okay? We've got 2 lectures. This is the cumulative national average pass rate, as I told you, and it's that's from the GCIE website. It's 88%. The pass rate for if you're a UK trainee, if you're non-UK trainee, is 44%. The overall national average is 70%. These are the figures from our pass rate. That's from the 7th, which is the one, not the results that came out last Tuesday. That's the results before. We had 97% pass rate among the UK trainees, 86% among the non-UK trainees, which is almost double the national average. And overall, it's 83%. This is the result from our last course. These are the results of last Tuesday, which, if you see that compared to the overall pass rate, it's better. And as I said, if you're a non-trainee, it's almost double. What's the most important behind these figures is not those who passed, it's those who did not pass. Okay, because we go very hard ourselves saying why this person and that person did not pass, and we go audit our reports about them, and everyone who did not pass has been advised not to sit for the exam. So I'm not saying that they've done the wrong thing. I'm saying that we would like to audit our assessment and how was that close to the real exam, just to find if there is anything that we can do better to help you. Okay, it's we're very close to each other. I think we passed the FRCS about 4 or 5 years ago. So our main focus is really to help you to pass and address all the individual weaknesses and anything we can do to help. This is the schedule for the mock. That's how is it done. It would be 40 minutes for general surgery, 1 long, 2 short cases, trauma and critical care. It's 6 short cases for 30 minutes, academic paper and basic science 30 minutes, and for specialty it's 40 minutes. Usually the mark that you will get in the mock exam, as I told you, it will be based on the most aggressive examiner what will give you. So most candidates found is slightly less than the level, but I think it's better than this. That's your comfort blanket. You wouldn't get less than that based on your answer. It's a very hard time. We do about 2-3 weeks over the mock. That's how the mock schedule look like. Okay, it's very meticulously curated and planned. And by the way, that looks something similar to the exam schedule as well. It would look like that. Okay. The Vivas, these figures are from the last course that has concluded last Tuesday. These are the hours taught. That's what you will get. You will get 20 hours in general surgery, and in things like breast surgery, you get things like 35 hours. And total of Vivas. This is just Viva. This does not include the lectures. The lectures are here only about 55 hours, and we conducted 94 hours of mock Vivas. So that's a wealth of practice. That's a wealth of practice. It's very rarely to find any topic or any question that's outside that at the end. And we do not aim to cover everything. I think the main thing is that you are confident how to answer, even if you get something that you have never heard about before. This is the last slide. If you want to leave, these are the most 2 available assets you will have if you go to the course. The first one is the LMS. The LMS is an application. You will have, it's in the App Store, it's in Google Play. Once you sign up, you will get access. It's very strict for a reason. LMS is the library. Okay, that's a library source. That's when we put all the things like when I showed you the gynecomastia guidelines and all these things. These are the things that we put there. And most importantly, we can easily just get everything and put it there. We appreciate your time, and I would not want to put anything that you do not need to read. So with the LMS, it is specialties, and with general and specialty, and you will find the things that you need to read. Okay, you'll find for the breast, I put the trial that they need to know about, and you have access to that on the go. Also in the LMS, you will find the previous videos, all the recordings, all the Vivas, and all that. Few things that we have done, and these are things that we cannot change, I'm afraid. Just due to the high security in the LMS. High security, I mean you cannot download the videos, you cannot record the screen, you cannot take a screenshot. It is only accessible from a single device at a time. So either it would be your phone when you can just revise on the go between the cases in theater or that, or if you prefer a bigger screen, it will be on the iPad or your tablet. If you'd like to access from a different device later on, you have to contact the IT. Our IT are available 24/7, so you can access you can contact them anytime. And it is, as I told you, it's very secure, just to protect the effort of those, because it's not just about the guidelines and about the papers and the whole thing. You'll find lots of, like that axilla scheme I showed you for the breast trainees, that would save about 6 or 7 hours of studying. Things like that, they would be built on the Telegram. So that's the effort of the mentors as well, that has to be protected. And the other thing is the Telegram group. As you can see, that's a screenshot from the previous course just before the exam. You can find things like more than 1,000 posts for the colorectal just on their own, and all. And you will always, whenever you post a question, you will find a mentor who's ready to answer, and that's an answer tailored to the exam, not just to the specialty. Okay. Any questions? Yes.
Yeah, just a technical question for the MLS for the part from security part. So if I log in from my mobile, so that's mean every time I have to log in from my mobile,
From
I
the
can,
same device. From the same device. If you try to log in from your tablet, it will not allow you.
even
But
if I log out from my mobile, I can log it from my tablet.
you have to contact the IT to give you access to another device before you revoke the first one. It's not a very long procedure. Usually they respond within 15-20 minutes. 24.
All right.
But you
Okay.
have to do that. You cannot log out and log in from another device. Just to make sure that only device. And even if you take a screenshot, they'll give you a warning and they will send something to the admin that that person has taken a screenshot. This is the only way we could do that. Before we had the LMS, we used not to record the lectures. Because especially with lectures, if that gets leaked and uploaded to YouTube, they lose its value, don't they? So just to protect your effort and your identity, there are things like that you are answering the virus. You don't want that to be on everyone's phone or anything like that. So yes, it is just part of that security there, but it is not very convenient, but it is doable, and we hear that all the time. You had a week at work and then you got that through the phone, but at the weekend you'd like to change that access to a tablet instead. It is doable, but it just involves some chatting with IT.
Okay. And up now there is no app for Windows.
Not sure about Windows. I think there is one coming with the Mac tool, but I have to check. There is something in development. Again, it has something to be checked to be very, very secure. As I said,
right.
we used to get we have this one is the 9th course we run. So I've been doing that for 4 years or 5 years. First of all, we used to record the Vivas, not give lectures at all. We wanted to give lectures, but we didn't want to give something like 15-20 minutes, something that you will find everywhere. But also, on the other hand, we want that to be very secure. Otherwise, that's useless. So we only had to wait for that app to be developed before we start giving the lecture. So this is security is a core thing. If it's not secure, we'll not go for it. I think they might be developing something for Windows, but it's not ready now yet. It might be within the next 2-3 weeks. But don't take my word for it. Mohammed Nef, yeah.
Suggestion. I would like to involve in Telegram discussion, but sometimes the timing of question is 9 a.m. Everyone is working. Faculty member put a question. After that, at 5 you go. All the discussion is done already. So if we put that, especially the discussion in more proper time, something after working, because when you have a question at 10 a.m. you will not answer that question. After that, you see that all questions almost done.
That's a very good suggestion, and we thought about that in the past, Mohammed. I think the internet is not great, but I get what you want. So you don't want the question to be posted at 11 a.m. when you are busy doing the ward round, and then by the time you are checking the Telegram, all the questions have been answered already.
Yes,
I get that. First of all, I don't want to suggest that because I want more questions posted during the day, not a question daily. It's not a daily quiz or anything like that. That's why I'm a bit reluctant to ask my colleagues just to post at 9. I want them to post at 9 and at 11 and at 3 at 4. So you get more exposure. You get 4 or 5 questions a day rather than one. We thought about that in the past, but you know that we all have different work patterns. Some of us finish at 5. Some of us, they're on call, they finish at 8. If you are night on call, you're starting at 8. It's very hard.
I agree that, but
but at least what we can do, we can try to post at least a single question at the same time daily, so that at least at 6 p.m. there will be a question.
Thank you.
Right. We will try, but I cannot promise anything. But that's a very good suggestion, and we thought about it in the past. The thing is, there is no one size fits all solution, I'm afraid, Mohammed. But we'll try to do our best.
Thank you.
You're welcome. Shukra?
I don't know what LMS is. It an app? How does it look like?
an
So I can
application.
download it.
It is an application. It is an application that's in the App Store or in the Play Store. You download it.
What is the full name of it? If that's all right.
Yeah, I'll show it to you. Just give me a second.
Thank you so much. And while you're looking for it, do you think I would pass that station?
Do I think you will pass that station? Which station will
The net cash.
You will get 6. That's a pass. That's not what you should do.
All right. Thanks.
You shouldn't aim for 6 because you will get another question that you wouldn't know.
Obviously, yeah.
And that's an easy one. So can you see my screen? That's my phone screen.
Okay.
Okay. So if you go to the App Store, search for PrepMedico.
Yeah.
You'll find that's one here.
All right. Okay. That's fine. Thank you. Thanks.
If you open it, it will look like this.
Okay.
It's a well-curated app. It will be something like I cannot access anything now, but
Yeah.
if you go, it will for the eighth FRCS course, which is the last one, be something like this. This will contain pictures, Viva recording. If you go to the e-library, for example, you will find that's general critical care, academic, exam guidelines, FRCS compilation for the breast general, and if you go for the general. These are the only things that you need to know.
That's all right. That's all right.
They didn't even give me access yet. It's premium content. So that's how it works.
That's all right. So PrepMedico. Thank you so much.
Any other questions? Okay. So if you've got any questions, you can message Manny, Mr. Manny Catherville. He's the course director. Manny is great. He's excellent. I don't know how he managed to do that, but every time one of the candidates message them, he answers within 15 minutes. I always ask him when he sleeps. He's very approachable. WhatsApp is the mean to communicate about anything. Is about the logistics, and with anything about any clinical questions, that would be the Telegram. And wish you all the best. It has been a pleasure seeing you today. Thank you.
Thank you so much.
Thanks.